Welcome, and thank you for joining us for our Research in Progress webinar series. My name is Carrington Lott. I'm the Program Manager for Systems for Action. And if you're not familiar with Systems for Action, we're a national research program of the Robert Wood Johnson Foundation, and we're housed at the Colorado School of Public Health. We support research across the country, testing tools and models that facilitate multi-sector cross collaboration between public health, social services, and the medical sectors, with the goal of improving population health and advancing health equity. Today, we're joined by Irene Vidianti and Will Nicholas from the LA County Department of Public Health, and they are part of our third cohort of grantees that are in the middle of their research project. And today, they will be presenting on their work that focuses on closing gaps in health and social services for low-income pregnant women. So like I mentioned, today we'll hear a quick presentation from Irene and Will, and then we'll hear commentary from Neshka Rikachevska, and Dr. Naria Robinson will also provide some answers in our Q&A section. And Dr. Naria is the medical director of the MAMAS program. And at the end of the presentation and commentary, there will be a brief Q&A section. So if you have any questions that come up during the presentation, please use the Q&A feature at the bottom of the screen. And with that, I'll introduce our presenters. So we have Irene Vidianti, who is the data scientist for the Los Angeles County Chief Information Office. We have Will Nicholas at the LA County Department of Public Health, who directs the Center for Health Impact Evaluation Center. We have Neshka, who is the manager of learning and evaluation at First 5 LA. It's a county commission that's focused on improving conditions for LA. And with that, I'm going to hand it over to the team so you can hear more about their research from them.
Great. Thank you so much, Carrington. So I'm just going to do a little housekeeping and check if I can indeed control the slides. Okay. So good morning, everyone, or good afternoon for those on the East Coast. My name is Irene Vidianti again, and I am with the Los Angeles County Chief Information Office. So before we begin talking about the study where we are evaluating this program called MAMAS Initiative, I just want to talk about the program itself, about MAMAS Initiative. And before we do that, I just wanted to start with some background to just illustrate why we need a different approach in a program like MAMAS. So the birth outcomes in Los Angeles County Department of Health Services, where MAMAS is located, and Department of Health Services is a network of safety net hospitals in LA County. The birth outcomes here are quite poor. And just to illustrate, here we have a graph of low birth weight, an indicator of poor birth outcome. And just as an illustration, we have the rate for Malawi here, and Malawi has been indicated by WHO as one of the countries with the poorest birth outcomes, and their low birth weight rate is 8%. And LA County fares slightly better at 7%. But if we look at the rate for LA County Department of Health Services at 13%, it's almost twice the rate of LA counties, and it is also far higher than Malawi. So I think that already gives you a sense of the poor birth outcomes and the challenges that are facing the prenatal population in LA County DHS. And if we look at the preterm birth rates, yet another indicator of poor birth outcomes, we are also seeing a similar picture where the rate for Malawi is 18%. The rate for LA County is better at 11%. But when we look at LA County DHS population, we have a rate that is very similar to Malawi. So I think this really shows that we need a different approach when it comes to addressing the needs of the prenatal population in LA County. So the team at LAC DHS serving the prenatal population realized that to change those poor birth outcomes, there is really a need to breach agency silos to address social stressors. So there is really a need to address the social determinants of health or social stressors that are contributing to the poor birth outcomes as well as the poor outcomes later in life, which are common in the DHS prenatal population. So the graph that you see at the bottom are showing the rate of social stressors in the DHS prenatal population based on the internal intake of its patients. And you can see that the rates are quite high. The rate of substance abuse, about 1 in 5 of the prenatal population have it. About 1 in 3 of the DHS prenatal population have issues with intimate partner violence. About 1 in 6 are housing unstable. So there is really a need to offer comprehensive services and supports to address this social stressors along healthcare provision so that we can really influence not only the birth outcomes, but also the outcomes later in life, as well as the outcomes for the moms in various different sectors. And the Mama's Neighborhood Initiative tries to do that by assessing clients' needs and connecting the clients to the services they need in the different sectors. It might be housing, social services, mental health treatment, and other needed services. And that is actually encapsulated in the name itself. So MAMAS is actually an acronym for Maternity Assessment, Management, Access, and Service Synergy. And the program is really called MAMA's Neighborhood because all these are offered throughout the neighborhood. So the core assumption of the program is what I just mentioned before, that there is really a need for a comprehensive, coordinated approach, including 3 core pillars of health: physical, mental, and social, to address poor birth outcomes. And the elements of the approach are also encapsulated in the name. So one of the elements of this comprehensive coordinated approach is assessment. So clients are consistently screened and their needs and risks identified, including medical, social, and environmental determinants. And then there's also management of access, where intensity of service provision is aligned with the identified risks that are identified through that screening and assessment. And then in terms of service synergy, there needs to be this coordinated and collaborative care across sectors to mitigate the determinants of poor outcomes, which can span across the multiple sectors and the multiple core pillars of health. And finally, this needs to be done throughout the neighborhood. So the program goes beyond the borders of the clinic to the community and partners with community-based partners and home visits. And in fact, that neighborhood network is quite vast. So MAMAS partners with a wide array of community-based agencies in all these various sectors. You can see that there's partners in mental health, intimate partner violence, counseling, housing, food banks, and so on, to try to really address those determinants of health and the social stressors that the clients may have. So with that, we're going to get into the research question and methodology for this study. So our overarching research question for the study is to evaluate the MAMAS program or the MAMAS initiative and look at the outcomes. And more specifically, we want to examine whether the outcomes among MAMAS clients compared to outcomes among moms who did not participate in the program differ. And specifically, we want to look at birth outcomes. So as we saw in that motivating background, we want to see whether the program has actually made a dent in those poor birth outcomes. But beyond that, we also want to see if we affect outcomes in other sectors too, in housing, in mental health utilization and mental health outcomes, in receipt of social service benefits and so on, to really see if we have made a change in those social stressors as well. And we also want to look whether the program is impacting health equity, specifically whether the high-risk groups that are served by MAMAS, whether their needs are adequately met, and whether the program has helped to reduce inequities in birth outcomes. And finally, we are also going to be looking at the effectiveness of cross-sector linkages across social healthcare and public health services across the network of partnership agencies that we just showed in the previous slide. And as you can see here, we are using 3 streams of analysis to answer the research questions: quantitative analysis, qualitative analysis, and network analysis. More specifically, we are using concurrent embedded mixed methods approach for our research. And the main component of which is our quantitative analysis, where we are using secondary data, a blend of the Countywide Information Hub, which is our database of administrative data, linking together data from multiple county departments, MAMA's administrative data, of course, as well as birth records. And we will be performing difference in differences analysis of the cross-sector outcomes. We will also be analyzing birth outcomes, and we will also analyze all this using match samples. So we will have a propensity match comparison group who will be similar to MAMA's clients, but who do not participate in the program. And we will also supplement the results of the quantitative analysis with network analysis and qualitative analysis. So for both of this, we are collecting primary data. For the network analysis, we are going to be collecting network survey from the partner agencies of Mama's Neighborhood. So those community-based partner agencies that you saw. And we will be constructing network maps of the partnership network and also calculating network scores to figure out the effectiveness of linkages across this community-based partner agencies. And finally, we also have a qualitative analysis component to this, where we will also be collecting primary data through interviews with patients, providers, and key informant interviews with senior level providers within the program, as well as within the community-based partner agencies, and analysis will be based on grounded theory. So because this is a research in progress seminar, we wanted to give some updates in terms of where we are and show results of really preliminary analysis that we have so far. I just want to acknowledge the elephant in the room, the impact of COVID-19 on the study. So COVID-19 has had an impact on our study in various ways. So for instance, we had to substitute focus groups for phone interviews for our qualitative data collection to abide with social distancing requirements, for instance, but it does also give us the time to add a few COVID-19 related questions to our primary data collection. We ended up having to push the timeline back for a few things. And since most of the study team members are LA County employees, we're involved in various COVID-19 related activities affecting our resource availability. And of course, our analysis will also need to consider how COVID-19 may affect outcomes. So just a note that we've had to adjust and adapt as things evolve, but I think that is something that all of us have had to do during this unprecedented times. So with that, I want to give some updates on each of the 3 streams of analysis that we have, and I'll start with the quantitative analysis. For our quantitative analysis, as I mentioned, we're using secondary data, but we do need to link the various secondary data that we use for the study. In LA County, we are actually quite fortunate to have this county-wide information hub, which links together already data from the various sectors within the county, from social services, housing, justice, mental health, and health. So this already exists, this information hub, this link database linking administrative data from these various county departments. And this county-wide information hub will also allow assessment of the cross-sector impact that I have mentioned before, because we have data across all the sectors, so we should be able to look at healthcare and mental health utilization, food assistance, income assistance, housing, and justice involvement, for instance. We do have to link the MAMAS administrative data to this information hub because even though MAMAS is a county program, that it is currently not part of the information hub yet. And we also will link birth records from the state to the information hub so that we can assess birth outcomes. And we plan to do that linkage in November. And once we have the birth records linked into the information hub and have the data linkage completed for this project, we will use the array of linked data to construct a comparison group of non-participants resembling MAMAS clients, which will be propensity match on individual characteristics, birth risk factors, social determinants, and prior service utilization. And we plan to do this construction of comparison group hopefully in December or early January. So the graph that I have here on the screen is showing you just the growth of the program over time. So we have the number of MAMAS clients by the year of intake. And as you can see on the screen, it's clear that the program has been growing over time. By now, each year, MAMAS is serving almost 3,000 clients. And as is common with a program as it evolves over time, the program implementation also has evolved over time. So I have here some time points in which different elements of the programs were implemented to improve the program. And that really means also that the so-called full implementation of the program really doesn't happen until around July 2016. That's when we can say that the program has fully ramped up and is mature. And because of that, we are restricting analysis for the study to clients who had an intake in 2017 and 2018 only. So that ensures that the program has been fully implemented and the clients are getting the full spectrum of program elements that they're supposed to get. And we also want to be looking at 1 year post-enrollment outcomes. And that's really why we're stopping the analysis to clients who are enrolled in 2018. Because if we also include the 2019 intake patients, then we will start seeing the effect of COVID and the outcomes for the 1 year post-enrollment results. So in 2017 and 2018, we have a total of about 5,000 MAMAS clients enrolled. We had to exclude a number of clients because we were not able to match them to the info hub, or the matching is poor. And we also excluded a few patients because they have multiple enrollments within those 2 years. So that gives us 3,600 unique clients for analysis in the MAMA sample. And all the results that you are seeing in the next few slides, and all of those are preliminary results, those are all based on this 3,600 clients. So these are some of the results of our preliminary analysis. All of them are looking at pre and post MAMAS enrollment, 1 year before enrollment in MAMAS and 1 year after enrollment in MAMAS. And just a quick disclaimer, all those results are preliminary. We're still refining our approach to analyze the data. These are sort of the more quick and dirty results that we have gotten so far because we wanted to provide some updates. So what we have on the screen here are the healthcare utilization of MAMAS clients for those 2 enrollment years, 1 year before enrollment in MAMAS and 1 year after enrollment in MAMAS. So I would like to draw your attention first to the blue line here, which is showing the number of unique MAMAS clients who have had any type of ER visits 1 year before enrollment and 1 year after enrollment in MAMAS. So you do see a decline 1 year before enrollment in MAMAS, almost 1,000 unique MAMAS clients, just the ER visits, and after enrollment, about 730. So that's a trend in a favorable direction. If we look at the orange line here that is showing the number of MAMAS clients with inpatient visits, we do see an increase from 300 to more than 2,000, but that is not a cause for concern. If you recall, MAMAS is a program for the prenatal population, so it is expected that after enrollment in MAMAS, most of them will give birth, and that's why we're seeing hospitalizations and inpatients for the MAMAS clients. And finally, outpatient visits have been high throughout. Most of the clients have outpatient visits, both before and after enrollment in MAMAS. And because of the population, again, this is the prenatal population, I think this is what we actually expect to see. We also look at the number of unique MAMAS clients experiencing mental health crisis. So this number is quite low to begin with. Even before enrollment in MAMAS, we only saw 86 MAMAS clients experiencing mental health crisis. And 1 year after enrollment in MAMAS, we do see a decline to 55. But again, these numbers are quite small. We also looked at justice involvement 1 year before and 1 year after enrollment in MAMAS. So this is also a relatively small number, although it's higher than that mental health crisis number that you saw before. So 1 year before enrollment in MAMAS, if we look at this yellow line here, we had about 150 unique MAMAS clients who were arrested by law enforcement for any kind of booking charge. And 1 year after enrollment, we see that number drop to 90. And if we break that down by booking charge, whether it's felony, misdemeanor, or other, we are also seeing those declines for all the booking charge types. And now we're looking at social service outcomes. If we're looking at enrollment in income assistance programs in CalWorks or GR specifically, we are seeing an increase, and that's a good thing because I think most of MAMAS clients probably are eligible for this income assistance programs. So 1 year before enrollment in MAMAS, we saw 600 clients enrolled in the income assistance programs, and that number increased to 1,000 after enrollment in MAMAS. We also see similar outcomes with regards to food assistance receipt. So we are looking specifically at number of MAMAS clients enrolled in CalFresh here. And CalFresh, for those of you who might not be familiar with it, is California's implementation of SNAP, or the Supplemental Nutrition Assistance Program. 1 year before enrollment in MAMAS, about 1,200 clients are enrolled in CalFresh, and 1 year after enrollment in MAMAS, that number has increased to 1,800, and that's about half of MAMAS clients. So that's a change in a good direction. So that's where we are with the quantitative analysis. With the network analysis, which is performed by Visible Network Labs, our partner, who will be conducting the data collection and the analysis. We have completed the first pilot of the network survey with the research team and a couple community partners in September. We are currently finalizing revision of the survey questionnaire based on feedback from the first pilot for the second pilot, and we are also currently compiling contact information for survey recipients in our partner organizations. We will then conduct our second pilot next month in November, and we plan to launch the network survey to community partners by late November. And hopefully the survey data collection will be completed in December. With that, I will hand over the reins to my co-PI, Will Nicholas, who will be giving us about updates on the qualitative analysis.
Great, thank you. Can you hear me?
Yes.
All right, excellent. Thanks very much, Irene. Let me just start by thanking you for all your hard work and leadership on the project. It's been a pleasure working with you on this, despite the difficult circumstances with the pandemic. I also want to thank Robert Johnson Foundation for hosting these really helpful research in progress webinars. So during my brief time with you, I'll be talking a little bit about our qualitative analysis, the qualitative portion of the study. We have a fantastic team of qualitative researchers from the Southern California Center for Nonprofit Management. I believe they're in the audience. They could be given these slides just as well as I could, but if we get any difficult questions about the qualitative data, I might just turn to them. So a little overview of, again, the components. The main kind of immediate impact of COVID was that we had to switch from in-person focus groups to phone interviews. So our plan is to conduct 20 patient interviews, 20 provider interviews, and about 10 key informant interviews. The patient interviews are well underway. We've got about 12. We have 12 out of the 20 completed there. We've purposefully selected patients who are both Spanish speakers, English speakers, African Americans, representatives of particular high-risk groups. So we have a good representation of the clientele. Our provider interviews, we are splitting those between what we call the core mamas providers, the clinicians, and mostly clinicians and care coordinators who work at the mamas centers. There's 4 of them around the county. And then the other half will be what we call these auxiliary providers, which are the providers in the broader network, who are many of whom will be included in the network survey. So it'll be interesting to get the perspectives of both of those groups of providers. And then the key informants will be the high-level leadership, both within the MAMAS program, but also in these cross-sector agencies whose impacts we're looking at through the qualitative and quantitative portions of the study. So the only data that we've collected so far is from the patient interviews. And if you'll go to the next slide, please, Irene. Thanks. Just a little updates of the 12, 6 were in English and 6 were in Spanish. And actually, before I start, let me address the top line there. So what we knew we wouldn't have a whole lot of data to share by the time of this presentation, but given the sort of all-consuming nature of the COVID pandemic, we thought we would try to share some top line findings related to clients' experiences with COVID, and particularly as it impacted their relations to the MAMAS project. So it is a section that we added because of COVID, and we'll just provide some brief findings from that portion of the survey. So of the 12 that we're basing these findings on, only 1 delivered before the Safer at Home order was established in LA, which is on March 19th. And it was very soon before. So the vast majority of these folks really were impacted by the pandemic. They delivered after the order went into place, and 1 was actually still pregnant at the time of the interview. We got good representation from all the 4 geographic locations of MAMAS programs around the county. Next slide, please. And so among those that we interviewed, the 75%, the preponderance of respondents, and again, we were focusing specifically on how the pandemic affected their interactions with the program. Broader preponderance of respondents said that it did not affect their interactions. MAMAS neighborhood staff continued to communicate by phone and were helpful in giving referrals to resources. And these referrals included often food pantry information and referrals, housing programs, and tangible goods like diapers and baby clothes. A lesser portion said that it did affect their interaction with the program, but most of those folks were people who had actual clinic visits that they experienced some challenges with, because during the early, and continuing in the pandemic, there's been, additional precautions put into place in clinical settings. So there were some challenges with that. But one thing I want to, so just because most of these folks felt that their interaction with the MAMAS program was not necessarily negatively affected by the pandemic certainly did have an impact on their lives. So I don't want to lose sight of that, and we'll be digging more into that, as we move along with the analyses. But so, for example, right, some lost their jobs, were feeling isolated and uncertain. And so in those cases, actually, the Mamas program was able to help with needs that surfaced because of the pandemic. So again, we'll be exploring that more as we move along. But that's all that we'll be sharing today with the qualitative data. So thank you very much, and I'll pass it back to Irene to talk about our next steps.
Thank you, Will. Oops, I'm not sure what just happened. Thank you, Will, for that. So we are about to wrap up our updates, but before that, I just wanted to quickly talk about our next steps with the study. So for the quantitative analysis, as I mentioned, we are planning to do difference of differences analysis of the cross-sector outcomes and analysis of the birth outcomes. And we also want to utilize matched samples for the analysis. And for that, we will need to construct the comparison group using propensity score matching. And all this also hinge on us completing the birth records data linkage into the information hub, as I mentioned, which hopefully we will be able to do by next month or latest by the end of the year. So for the network analysis, as has been mentioned, we will be conducting a second pilot of the network survey shortly, and launching the network survey before the end of the year, and hopefully we'll have results by the end of the year or early in January. And as Will has mentioned, for the qualitative analysis, we're finishing the patient interviews, and we are also going to be conducting analysis of those patient interview data, and we will also be scheduling provider interviews shortly, and we are also developing interview guide for the key informant interviews. So finally, before I hand this off to our next speaker, I just want to acknowledge the team, the wonderful team that Will and I are working with for the Systems for Action Mamas study. We have a great team comprising folks from the different county departments, as you can see here, from Public Health, Chief Information Office where I'm in, but also Department of Health Services. And we also have fantastic partners from Southern California Center for Nonprofit Management and Visible Network Labs. And if you have any questions after this presentation, my email address as well as Will's are also listed here, so feel free to email us. And with that, I am going to hand over the reins of this presentation to Neshka from First 5 LA, who will be our commentary speaker for today. Neshka?
Thanks, Irene. So today, I'd like to provide some broader context and really highlight some of the promising aspects of this research that jumped out at me. And I want to start with the power of linked administrative data. Here in LA County, we are very fortunate to have the countywide information hub with linked data from all of our county departments that is being leveraged in support of this research. In my experience, to be honest, there are very few data resources of this nature available to counties, and I really don't want to diminish the amount of work and collaboration it takes to develop a repository of linked administrative data. However, I believe that this research highlights the long-term benefits of investing in such resources. So first of all, resources like the Countywide Information Hub really help us avoid prohibitive costs in research. So typically, a longitudinal study such as this would rely on primary data collection. It would be prohibitively expensive with lots of questions about self-report bias. Likely, as a result, it would focus on a very limited set of outcomes because it would be too expensive to look at more. Instead, with the Countywide Information Data Hub, we can really leverage already existing data from multiple sources. We can see longitudinal effects at a much lower cost. And that means we still have the resources to have the ability to really dig deeper through some of the qualitative analysis that William shared. But it's not just about the money, and I do want to emphasize that, because it also reduces research burden on families. Typically, when we're doing this type of research, we're asking really sensitive questions of families. And if there's things like negative birth outcomes, we're asking them often through these questions to relive some of the traumas they experienced. Instead, we can really look to the already existing data, to questions that they've already answered, and it prevents them from having to re-experience some of these traumas through our research. It prevents them from having to answer the same questions over and over again when we already have this data existing somewhere else. So I really love that this research is able to use administrative data in this manner. I also love that this research is really taking a cross-sector nature. And that means it's breaking down silos. Programs such as Mama's Neighborhood really recognize that families don't exist in silos, that their health is not separate from the social stressors they experience. And I think research in general needs a similar breaking down of silos where we look more broadly at outcomes across sectors, because this can provide evidence to those sectors that typically wouldn't think of pregnant moms as part of their responsibility. Like, what do prenatal programs have to do with the justice sector, for example? Well, research such as this one that takes a cross-sector look can really provide that answer and help find additional partners, funders, and champions for our programs in places where we typically wouldn't expect them. And in our work with First 5 LA, we're really starting to see a lot more champions from genuinely places where we typically wouldn't have looked, simply because we've been able to provide the evidence that programs like Mamas, like home visiting programs, really have long-term effects that affect all aspects of a child or a family's life. And again, having a resource such as the Countywide Information Hub are really essential to facilitate this type of work. I think here in California, we're starting to see recognition of this with increasing investments in longitudinal cross-sector administrative data resources, with efforts such as the Cradle to Career data system at the state level and the Children's Data Network here more locally in LA. Now, I do want to recognize these data resources are not perfect. They're not going to have all the data that we need, but they are a powerful tool to supplement what we're already doing in research. Finally, I want to speak to the importance of programs such as Mama's Neighborhood. As a systems change agent here in LA County, First 5 LA really works hard to understand how families are experiencing our child and family serving systems. And the number one barrier we hear about is how difficult it is to navigate these systems. There's confusing and conflicting information available to these families, and programs such as Mamas provide the critical glue to connect them to the supports that they need. It's not necessarily that there's not services or there's not supports available. It's about ensuring that the families who need them are actually connected and linked with them. And that takes a program such as Mamas. And I think the important part when we do take this cross-sector look at programs such as Mamas is that we get to really understand that we're not just avoiding negative birth outcomes. We're really providing assets at birth to the children that go through these programs and the families that go through these programs. And so really trying to take a positive look at this, that the effects of programs such as this really do not end just at birth, but really have ripple effects throughout our communities to create strong children, strong families, and strong communities. So with that, I just want to close with just kudos to both Mama's Neighborhood and to the research team for really taking such a broad look at the effects and the impacts of such critical programs. Back to you, Irene.
Thank you so much, Nashka. And I believe now I'm turning this over back to you, right, Carrington?
Yes. So thank you so much, Irene and William, for giving us an update and sharing some preliminary data on your research. And thank you, Neshka, for providing some great insight into this project. So this is going to bring us to our Q&A section. And we've got some great questions that have come in so far, and I invite you again to use the Q&A feature at the bottom of the screen if you have a question. First, we'll ask a couple of questions that were emailed to us in advance, and I believe these are directed to you, Dr. Nuria. So the first question is, can you discuss postpartum care for women who give birth, especially if they needed extensive medical care during pregnancy or at the time of birth? In recent work in New York, we found many women, including those on Medicaid, did not have access to such care.
Certainly. This is a really great question. We at Mamas really are interested in supporting women both during pregnancy as well as in the postpartum period. And I think the postpartum period is the time when many women kind of get dropped. And during pregnancy, women have quite a few touch points with the healthcare system. They see the provider at some points toward the end of the pregnancy every week. And then in postpartum, we only have one visit, traditionally at the 6-week mark, which is woefully insufficient, we all know, in order to provide adequate support for what is a really difficult time for many moms, especially women of color. So with Mama's Visits, we extend the services that you've heard about from Mama's Neighborhood to women at the highest risk for poor outcomes through the baby's 12th month of life. So we work with these women for a year following delivery. And this includes care navigation, as was just alluded to, which is often very challenging for women, especially who are non-English monolingual patients and those who potentially have substance abuse disorders or mental health conditions, which really make coordinating and arranging appointments and follow-ups very challenging. We support the dyad in general, providing education to women through our public health nurses around breastfeeding. We talk about the importance of infant and childhood vaccinations. Our psychiatric social workers can provide therapy for women who are struggling with serious mental illnesses, and our community health workers, who are part of the home visitation team, continue helping women with housing and food insecurity issues or other things that they may need from a psychosocial perspective that we often don't think about anymore once the woman is delivered.
Thank you so much for addressing that. I'm curious if you could discuss a little bit about the biggest barriers you've had to overcome with the pandemic and providing this postpartum care or connecting mothers to postpartum care.
This has been a really challenging time for, I think, everyone, including our field teams, because as you know, home visits are not being conducted right now. And so our field teams are having to use telehealth in order to connect with the patients. And some of our patients don't have data. And so doing telehealth and especially video visits has been challenging in terms of breastfeeding support and being able to connect with moms in the way that they were connecting with moms pre-pandemic in person. Additionally, our teams are really the lifeline for many women in terms of providing needed basic things like diapers and cribs and playpens and other things that we don't really consider as essential. But for our moms who can't afford some of these things, the Mama's Visits team are really the only people who are able to keep them going. And during the pandemic, resources have been scarce in general, but also because they haven't been doing home visits, they've had to really think about how to deliver these things in a socially distanced fashion in neighborhoods where it may not be safe to leave things outside patients' doors or on their curbs for fear of someone else taking them, et cetera. So it's been a challenging time both for moms and for the teams who really want to assist the moms as much as they were doing pre-pandemic, but trying to do it in a different way.
Great, thank you so much for addressing that. So that was the first question that was emailed to us in advance, and the second one is about prenatal and birth support. So it's on the other side of the spectrum. So the question is, our community has one of the most persistent disparities in infant mortality rates between Blacks and whites out of all counties in Ohio. However, they only have one birthing hospital. What are recommendations for developing comprehensive prenatal and birth support that is culturally effective and offers services that moms and families need?
That's also a really wonderful question. An effective prenatal care program really has to focus on mom. So at mom is the center of the prenatal care program. When we think more traditionally about prenatal care models, they usually revolve around the doctor. And while I'm an OBGYN, I'm very clear that our involvement in the pregnancy is not ultimately what actually is the most beneficial for mom. When we think about Maslow's hierarchy of needs, we know that the higher level needs must be met in order to influence behavior. So we can't realistically ask moms to focus on attending prenatal care visits when she has no roof over her head or no food to eat, or she's in a relationship that may be abusive, or she has a substance use disorder. So comprehensive programs really must address the stressors that will undoubtedly affect the pregnancy and the pregnancy outcome. Thinking about, especially the current landscape of the United States and where we are in terms of health disparities in maternity care and outcomes in this country, attending prenatal care visits is important, but it's only a small contributor to positive outcomes. Really building trusting relationships with patients in the prenatal period and during the labor course is really vital to successful birth outcomes. Mamas was intentionally built around this idea of the mother being the center, and she's surrounded by community health workers and other sources of support who, when possible, are also culturally and linguistically aligned. And also, in many cases, our community health workers come from the communities where their patients they serve live, which is a big deal in terms of being able to relate to the patients and understand where they're coming from. The other things that have been helpful in terms of birthing support has been shown in the data is offering doula services, particularly to women of color who may have limited support during labor and also postpartum doula support, which has also positively impacted not only delivery outcomes, but also breastfeeding experiences. You asked a question also about LAC provision and contraception postpartum. It is vital that women who are not only trying to live, but also trying to provide the best life for their new family have access to the contraception that they want and that they are desiring. So you really have to find mission-aligned healthcare providers, both at the hospital and the clinics, which feed to the delivery hospital, who will be willing and able to provide long-acting reversible contraception and really be able to counsel mom effectively on what the options are and what the access is to those options.
Thank you so much for addressing that. Next question we have for the qualitative interviews, how did you come up with the interview outlines and questions for the patient, provider, and the key informants?
Can you hear me?
Yes.
Yeah. Well, that's again another benefit of this kind of team approach that we've been discussing. So yeah, we brought on folks from the Southern California Center for Nonprofit Management to actually conduct the interviews. But when it came to developing the survey questions, they were developed in collaboration with Mama's neighborhood program staff, also with researchers on the team. But the general idea was to while we're going to be learning a lot from the qualitative data on some of these birth-related outcomes and outcomes related to use of services across sector, we wanted to look and see kind of under the hood a little bit more about implementation issues, right? So, and that was helpful to have the Mama staff involved in that. We wanted to see from the intake process to how referrals were made, to what made referrals more successful, how patients perceived the benefits of the programs and what impacts they had on them. That's also useful to supplement some of the quantitative measures of outcomes. So yeah, so definitely a collaborative approach to the development of the surveys questions, and very much looking forward to the opportunity to share findings when we have them.
And I have a follow-up question that was entered into the chat box, and you touched on this a little bit in your presentation, but what are the demographics of persons interviewed? Someone wanted to know that, and I'm not sure if they're referring to the patients that you're interviewing, the providers, or the key informants. So if there's anything else you'd like to share about the demographics of those interviews, please do.
Yeah, that's another good point. Not, beyond the actual development of the tools, we in terms of who we interviewed, who were sampled, and so we worked with the care coordinator of the Mamas program to kind of look through their roster of clients. First of all, we had to start by looking at those who had consented and given permission to share their information, their personal information. And once we'd done that, we knew that we wanted to make sure of our 20 interviewed, we had a critical mass of monolingual Spanish speakers, a very important and large population here in LA County, critical mass of African American moms. We also made sure we had some folks impacted by the justice system. So we've included purposefully included some of those mothers. And finally, there's a piece of the program that is for the most particularly high-risk women, which includes home visits. And so by making sure that we included some of the mothers who were in the home visiting program, we also ensured that we had some of the highest risk women. So that's how we made sure we had the representation that we wanted in the patient interviews.
Great, thank you so much for clarifying. Yeah. Irene and Will, I believe this next question or couple of questions will be for you. There were a few that came in, so Irene, if I missed any, please go ahead and address any that you see. But this first question is, how did you facilitate the formation of the LA County Data Hub?
Thank you, Carrington. And I think I do see a number of questions on the formation of the LA County Data Hub, both in the question and answer as well as on the comments to the answered questions. So I'll try to synthesize the answers for the various questions. So this is actually probably a question that has a much longer answer than what we can provide here. But really, it's a county-wide effort, and we are fortunate in LA County to have the support from leadership at the highest levels for the formation of this LA County Information Hub. And of course, the formation of it requires the collaboration and the cooperation from the various county departments who are part of the information hub. I think I saw a question about how this works out and how did you get the approval from the different data owners and how did you protect the participants' privacy and confidentiality as part of this data hub that we have. So a crucial part of this formation of the data hub, as some of you who have dealt with data sharing might not be surprised about, is that there's a big legal barrier that you have to get across. So obviously, with a data sharing effort like this one, where we are connecting data across multiple sectors, we have to work with legislation at various levels at the federal, state, and the local levels concerning the different types of data for the different types of uses. So we have had them. We have had to do this legal analysis in the county to try to figure out what kind of data is okay to share at what level for what kind of purposes. And I think that legal analysis is key to us being able to start doing this data sharing and getting approval from the different data owners, because I think that's the biggest barrier that we face, that the data owners basically question, is this legal? And so that legal analysis really help open the doors to facilitating the formation of this data hub. And that legal analysis is also key in terms of protecting participants' privacy and confidentiality, because as I mentioned, that legal analysis is done to see what is legal in what kind of use cases. I think I saw a related question about asking participants to give consent for the research when it comes to this linked data. So part of that legal analysis is to look at whether it's legal to for researchers like myself and Will, for us to use the linked data if it is anonymized for research purposes. And the legal analysis answered that yes, that is indeed the case. So for us, for researchers, we never see any identifiable information in the data. We have a separate team in the Los Angeles County Chief Information Office who deals with the linkage and anonymizing of the data, so that when it gets to analysts and researchers like myself, all we see are anonymized, de-identified data. And legally, we can use that data for analysis and research purposes without having to obtain consent explicitly from the clients. So I think that that really addresses another big barrier to research like this, where we're using longitudinal linked administrative data. I'm trying to see if there are any other questions around the data hub, but I think I've addressed most of the questions on the data hub. And
You did.
and let us know if there are any other questions in the Q&A box.
Yeah, thank you so much, Irene. I think you got all the ones I saw as well, so you did a great job of synthesizing all of those. For this next question, I'm going to move away from data and move into questions about incorporating the social sector. So Devaya's question is, how do social workers facilitate?
Dr. Robinson, would you mind taking that?
Sure. When patients get enrolled into the MAMAS program, if they have psychosocial needs that would be best served by the social worker, the patients are referred to social work services. And the social workers help with all sorts of things, including mental health disorders, additionally things, intimate partner violence, which a lot of our patients are victims of. They assist with food and housing insecurity as well with the community health workers. And then they also help integrate other community resources into patients' kind of care plans. Each of our patients, after their intake visit with the community health worker, has an individualized care plan. And so the social workers assist with trying to facilitate the referrals in the community for patients, which can best serve whatever the needs are the patients have. And the patients tend to prioritize the needs themselves so that they feel as if they're being served in the way and in the manner in which they desire and are ready to be served. And so social work helps to kind of prioritize these things with the assistance of mom, and also get them the help they need. Postpartum, our social workers in the home visitation portion of Mama's visits assist with therapy, primarily for women with severe mental health disorders who maybe not be on meds, but have serious challenges in this department, and maybe some who don't want to leave home. And so this is ideally suited for women who either decline going to inpatient services or decline even going to outpatient services, but are willing to speak to a social worker in the comfort of their home. And they, of course, do the mandatory reporting if the DCFS or Department of Child and Family Services needs to be involved in for any reason.
Great. So I think we're going to have time for just one more really quick question. And Dr. Nuria, I think this might be aimed towards you. So Eva Powell asks, the health plans I work with say that the biggest barrier to connecting with their members who can benefit to similar programs is learning of a pregnancy early enough. What are some ways that can enhance their outreach to learn of a pregnancy sooner for their members?
This is challenging because I think, I see the follow-up question here was asking about the benefits. The members have to honestly know what the benefits are so that they know to inform the healthcare plan of the pregnancy. The beauty of our program is that nearly all women who enter prenatal care within LA County Health System are offered the Mamas program. And so they don't have to rely on Medi-Cal or any managed care system to refer them to the program. And so potentially just having availability of programs, the knowledge of the clinic staff and of those who schedule appointments, et cetera, having them be knowledgeable also about community resources and programs such as Mamas that may be beneficial to patients. That may be one way to get patients enrolled very quickly. But otherwise, it's challenging. The patients just have to really know to let the healthcare plan know, and then also be aware of what services are available.
Great, thank you so much for addressing that. So that's going to bring us to the end of our presentation. I want to thank Irene and Will and Neshka and Nuria for joining us today and sharing information about their project and about their programs. If you would like a certificate of completion, there will be a brief survey at the end of this webinar, so please fill that out. And then, like we mentioned at the very beginning, this is an ongoing series of research and progress webinars, and we have other projects that we'll be presenting. These are our last two for the year, so please join us on November 11th for our Georgia State University team talking about subsidized transportation to slow diabetes progression. And then December 9th, we have our team from Cornell University speaking about financing coordinated medical and social services for patients with psychosis. And this LA County team is in the middle of their project. So if you'd like to stay updated with their findings as they learn more, please join our Systems for Action newsletter. We will always share their findings and help disseminate and communicate their findings. And you will be able to find out about their next Research in Progress webinar. And as always, we want to acknowledge that we are funded by the Robert Wood Johnson Foundation. So a big thank you to them for all that they do for us. And that will bring us to the end. Thank you so much for joining, and I hope you have a great day.